Wonderful to have you on, Renee. Thank you very much. And I'd like to pass it over now to Don Jones, the chair of the Digital Medicine Society. And he's going to be moderating this panel with Sara Vaezy and April Smith-Hirak, giving us some insights into how digital is having an impact on driving health equity at the government and private standpoint. So over to you, Don, and looking forward to the conversation.
Thank you very much, Jerry, and welcome to Sara and April to our meeting. And I'm chair of the group at DIME, not overall DIME, just for clarification, we're the ones focused on virtual first healthcare delivery. But maybe just a brief introduction by Sara and April, and maybe I can ask Sara to go first.
Thank you, Don. Hi, everyone. I'm Sara Vaezy. I'm the Chief of Digital and Growth Strategy at Providence, which is a large integrated delivery network based in the Western United States, from Alaska all the way down through Texas and New Mexico and several states in between.
Perfect. And April?
Hi, good morning. I'm on the opposite end of the country. I'm April Smith-Hirak, and I am the Regional Health Administrator out of the Federal Health Department in the Office of the Assistant Secretary for Health. And I cover what we call Region 2 affectionately. It's New York, New Jersey, Puerto Rico, and the US Virgin Islands.
So April, we chatted earlier, and obviously you're very focused on population health. And we were chatting a little bit about the notion that sometimes the federal government is kind of behind the times, and especially as digital health goes. But I brought up a couple examples where maybe you're actually ahead of the times. And maybe you could just describe your thoughts about digital health as it affects policy and population health from your perspective.
Sure, I think it's a really complex interplay, actually, Don. I think that population health and digital health have a lot to learn from each other. And I think that we have, on the one hand, in the government, we have our behemoth CMS, Medicare, Medicaid, who has the trend-setting ability to take an entire reimbursement industry and change the paradigm in which we operate and how we kind of practice medicine based on those reimbursement decisions and some of the guidance that can come out of there. On the other hand, if we are a little bit slow on the uptake when there's emerging technology and we're not able to take advantage of that, it can actually work to the detriment of that emerging technology. So I think it's a pretty interesting interplay.
Yeah, it's definitely interesting and obviously sometimes frustrating to everybody, I can imagine. And I imagine you hear about that when it does get to the point of being frustration. But we are seeing some pretty interesting programs. And we talked just briefly, and I know you're at least familiar with it, if not in the details, of the CMS ET3 program, which is using that carrot and stick approach to reward EMS systems that are changing the paradigm of transporting everybody to the hospital and offering alternatives of telehealth in place and or navigation to in-network facilities or urgent care centers, mental health facilities, et cetera, and still allowing the EMS agency to get paid for that response instead of only getting paid for a transport. So that's definitely an example where the economics have been changed to cause a different result. But from your perspective, and you think about population, do you see these kinds of programs potentially developing a significant impact on the population with, in this case, the alternative destinations and or not even taking to the ED?
Oh, yeah, absolutely. I think what it does, during COVID, our biggest concern was the increased pressure on our healthcare system and on our hospitals. So what happens when you have this influx, and what happens if we don't have a different model, or we have this ability to divert people from the emergency room to places that are actually better suited to treat them in many cases, and put them in more appropriate medical care? It can also depressurize the medical system in a situation like COVID. So that's a prime, very recent example. But I think that we see even more examples of that as we move. And as we begin to see this shift in helping move our system from what I like to call like the sick care system, where what we do is we treat illness, to a well care system where we help support the wellness and health of everybody. I think that this is one example of a way that we can start to push and nudge and shift the care for folks into a more appropriate payment modality that really supports the economics of a well care system.
Well, you prompted me to think, and I'm going to ask this question, which probably is really hard to answer, but I'm going to ask it anyway. And that is, if you look in your crystal ball, is digital health going to have more impact on the sick care system or on the health creation system?
Well, I wish I had my crystal ball a little bit less foggy. I think that it could go either way. I think that, in the traditional system, digital health has a role to play. And until we get to that well care system, there's an absolute role especially in equity and equity of access for digital health. I think that there's an amazing potential for that. And if we employ that potential, I also think that digital health could be a key component to moving us to that well care system.
All right, very cool. Well, maybe if I can shift to Sara and talk about it from the perspective of a large private healthcare delivery system. Sara, can you talk a little bit about some of your initiatives and how you're thinking about using the digital health, especially as it relates to access?
Yeah, absolutely. And just to build a little bit on what April said, I think, my crystal ball is also very foggy, but I think, how we see the world is that it's probably going to be sort of bifurcated between the traditional model, the sick care model, and the value-based health-based model for quite some time. So we're going to live in that mixed model, and everything that we're doing within the context of digital health is really intended to function in either. And the degree to which we can drive adoption or actual uptake in certain things from a sustainability standpoint will obviously be impacted by where we sit from a payment model perspective. But everything we're doing is intended to help our system kind of sustain in either model. And so just by way of example, I'll actually start with one example, which is very timely, and April referenced it with respect to COVID, where we had one of the first COVID cases in the United States back in January of 2020, which feels like an eternity ago. And we quickly mobilized to kind of have this end-to-end from discovery through the actual monitoring of care kind of in place around a COVID specific use case to do some of the things that April referenced. So decanting the facilities, ensuring that folks could avoid exposure, we could preserve PPE, et cetera. So we put in a consumer awareness hub around education, content, et cetera. That's where COVID chatbot lived that answered questions, did screening, directed folks to testing sites. We had a pretty comprehensive sort of real-time availability testing information from our facilities on that COVID awareness site. And then when we saw patients that needed care, we actually, but they were not sick enough to need care in the facilities, we actually onboarded them onto home monitoring for their COVID symptoms. And that was sort of this whole end-to-end thing that we put in place. We also did quite a bit of work around virtual visits. So, assessing patients with a clinical provider virtually. And we had a platform in place that basically scaled like 30 to 50x overnight. And then we took a lot of those things and have now expanded upon them. We had been working on them before. We got a tremendous amount of uptake and adoption under the COVID circumstances, and now have continued to push them across the system, whether it be with respect to ambulatory telehealth, urgent use cases around telehealth, as well as continuing our home monitoring program and expanding it to additional use cases around chronic disease management. We had a very long-standing telehealth program from an acute standpoint as well that's been very well established and is continuing to see many patients per year. We're actually tracking toward over about 1.5 million visits per year via telehealth. And the next kind of epic for us, I think, is making these more sustainable, building them more into our operating model, and not thinking about virtual or digital as substitutive, but really as core to a transformed system and operating model.
Yeah, that's great. Maybe we talk a little bit about the strategy that you're employing, and even more specifically with, frankly, the senior management of the whole organization and even the board of directors, as they think about how do they manage on one hand, the very attractive elements of increased access and increased services and perhaps throwing a broader net of care availability out there, while simultaneously recognizing that most of the reimbursement structure is really focused on bricks and mortar and perhaps drives a lot more dollars than currently the virtual systems drive. And you have to live, you've got to pay for that capital structure you've invested in. So how are you thinking about it strategically to make that shift you just described?
Well, there's a very deliberate move toward making the shift. You know, I think before COVID, there was the movement toward value was started with, it had fits and starts, and some successes and some not so much success, and so opportunities, and now we actually have, you know, what's happened in the last 18 to 20 months or so has really shown us that we have to be first movers and we have to move toward value aggressively, and that business model shift is something that we're doing very deliberately, and then orienting the delivery system around that. We can't, none of this is changing overnight, but for instance, optimizing our continuum of care, exactly as you described, to more ambulatory, heavy investments, investments in virtual, so that we can slowly start to manage the transition economics without tanking our kind of current system, which is already fragile given everything that's happened. So, you know, movement toward value is happening very deliberately, and then a whole bunch of things around continuum of care, utilization of digital, deconstruction of our health system are happening in support of that.
Yeah, I've been involved in value-based care for about 25 years, and one of the observations I've made, and it's not scientific, but is that when you run a healthcare system or healthcare service and you have a mix, you have kind of a fee-for-service mix and a value-based mix, you end up having to reach about 40% of your revenue at value before you kind of shift gears and focus entirely on the value structure. And what I find is that healthcare providers have difficulty being schizophrenic and running both mindsets. But there's a trip point that occurs somewhere between, and I just observed it to occur around 40% revenue coming in from value. Does that ring a bell to you as being potentially an interesting marker?
It does, and we have seen similar things within our system, but we also know that it's really difficult to, like, you know, you've got to, it's not a light switch, it's a spectrum, and so we're trying to put in place the metrics, the governance, the sort of pathway to get there, and some of the infrastructure, making, you know, some of the infrastructure changes and putting those technologies in place, for instance, that can enable us to do that. It's never going to be easy. There's a tremendous amount of provider engagement that's occurring, and so it's all kind of happening in concert with one another. But I don't know. There's no silver bullet, I guess, is the way that I would say it. But we're working to put in sort of the enablers to make that transition happen.
Well, Sara and April, thank you very, very much for your comments. Really appreciate the perspectives from both the federal government and from a large health system. And I know it's tough. It's tough to make the change. But it's good to see that you're working in the systems there that recognizes there's value and opportunity in making that change, and you're moving in that direction. And I know, because you're already a multi-regional network, you realize this can actually allow you to throw an even bigger net out there to provide services. So that's great. Well, thank you very, very much. And we'll go back to Stan.
Yeah, thank you.
Yeah, great conversation there, guys. Thank you very much, April and Sara, for giving your insights from those two different perspectives. And of course, thank you, as always, Don, for being a staunch supporter of the HIT Labs Symposia on a regular basis. So wonderful conversation to be had. I'm sure we could have definitely gone on for much longer, but no, unfortunately, we did run out of time. But really honored to have you all on.